to our afternoon session at the ARC UCT Public Policy Congress. If you're a person with a developmental disability, or a parent or a sibling of a person with a developmental disability, you know all about the challenge of trying to find health care. There are lots of gaps, but there are some opportunities as well, as we'll find out in the following discussion. Let me do a quick introduction of our panel members, and then I'll get out of the way for their presentations. First up is Dr. Clarissa Kripke, MD, FAAFP. Dr. Kripke is a clinical professor and director of the Office of Developmental Primary Care at the University of California, San Francisco. For more than a decade, Dr. Kripke has provided primary care to some of the most medically fragile and behavior-challenged regional center clients in the San Francisco Bay Area. After Dr. Kripke, you'll hear from Dr. Matthew Kaufman. Dr. Kaufman is CEO of Station MD, a telemedicine organization that uses technology to improve access to medical care for people with IPD. He also serves as the medical director of the emergency department at Jersey City Medical Center in Bayonne. Next, you'll learn about an effective health advocacy concept from Jennifer Drussen. Jennifer is with the ARC of San Francisco and is the director of its health advocate model. Jennifer has been with the ARC of San Francisco for over 9 years, but has 20 years of experience with people with developmental disabilities, including job support, supported living, and community building in Chicago. She also worked in England as a case manager for adults with IDD. And then you'll hear from Gladys Rodriguez. Gladys has been a client of the ARC of San Francisco for 9 years and is a member of its board of directors. She recently worked at Mission High School as a mentor and regularly attends Friends Like Me. And we'll start the panel discussion with Dr. Kripke.
So I'm going to start off by giving us a little bit of an overview of what some of the issues are, where we've been and where we're going, and then turn it over to my colleagues who are doing really innovative work in the field, and then we hope to leave a good portion of time for some questions and answers and discussion. So when we started closing institutions in the late 1970s, we knew that we needed to develop services for kids. And at the time, the life expectancy of people with developmental disabilities wasn't as long as it is now. It now approaches that of the general population. And therefore, we really weren't focused on developing a system for serving the healthcare needs of adults. We were mostly moving people from institutions into licensed group homes with 24-hour care. And we just heard a great talk about the transition from that model, which in many ways wasn't that different than serving people in institutions, into a more self-directed, person-centered, integrated model. And so when we were moving people from institutions, we built group homes that had, if people had complex medical needs, we were moving them into group homes that had 24-hour care and had nursing built into the program design and other medical services built into the program design of the group homes. We were also at the same time firmly invested, and we still are, in moving away from the medical model of disability, because we were promoting the idea, and we still are, that disability is not illness, and we don't want to go back. People with disabilities can be healthy, and but I think that in our zeal to do that, we maybe didn't acknowledge as much that sometimes people with developmental disabilities do have special health care needs that are a little different, or special health care delivery needs that accessing care through systems of care that were designed for people who didn't need long-term supports and who had less complicated combinations of medical, behavioral, developmental, and mental health issues needed something a little different. And so we know that separate isn't equal, and we want people to be included in their communities, to go to their local healthcare centers, to go to their local hospitals, but we didn't really work on developing a system for adults that met their special needs as well. What we did do is we did an awesome job of making sure that people with developmental disabilities have health insurance. There's nearly 100% of people with developmental disabilities are insured, making sure that once they had health insurance that they had a personal physician and that they saw their personal physician on a yearly basis. So everybody should be perfectly healthy then, right? So fast forward 40 years. What's happened is, like I said, the life expectancy of people with developmental disabilities has improved a lot as their conditions improved, and also improvements in ICU care and antibiotics have helped a lot. And a growing number of adults with very complex medical, behavioral, and mental health issues are living in community settings, which is great, but they're trying to seek care in medical offices that really weren't designed for that. When you have people with really complex needs, you really need interdisciplinary team-based care and more than 15-minute appointments, and you need accessible environments. And you need to interact with the full team of people that are providing support. And a fast-paced primary care clinic is not really designed for that. That doesn't mean that many people can't get their care in that environment if we provide appropriate accommodations, but for people with the most complex needs, it can be a challenge. So also, the majority of people living with developmental disabilities are not living in group homes anymore. They're living with families or in their own homes with support. And they need the same, and yet they need the same kind of things that people living in group homes had in terms of medical case management, training, transportation, systems of independent oversight, the same kinds of services that people were accessing by being in group homes. Just because people live in different environments doesn't mean that they don't also need those services. So we've discovered people with disabilities aren't sick, but they do get sick. And when they do get sick, sometimes that happens more often. There are risk factors that make people more susceptible to getting ill, and sometimes it can be more serious or take longer to recover. And it also, when people with disabilities get sick, it frequently requires changes to their services, supports, and at the moment, unfortunately, it often leads to housing loss, which is something we need to talk about from a policy perspective. Because when I get sick, I don't lose my housing. When other people get sick, they don't lose their housing, and we shouldn't be doing that to people with disabilities. Family, direct support professionals, service providers, are frontline health professionals. They serve a really important role in recognizing illness, in collecting health data, health-related data, in addressing insurance issues, in providing part of the medical history, not all of it, arranging the logistics of getting to a clinician in a timely fashion, deciding how to make that happen, and monitoring and following through on the healthcare plan. And if you've ever had the responsibility to do this for somebody with a disability, whether it's a family member, a parent, you know that it's time-consuming and it's complicated. Tasks in an institution that would have been performed by trained and certified professionals under the direct supervision of licensed healthcare professionals are often now being performed by family members or IHHS workers or other direct support workers, and people doing that important work, that work that takes skill. They need training, they need support, they need help. They need someone, a licensed healthcare professional, to interact with when they have questions or when things aren't going the way they expect them to. According to the National Core Indicators, despite our very high rate of complications and hospitalizations, people are not getting preventive care at the rates they should be. They have insurance, they have doctors, so why are only 30% of regional center clients getting flu or pneumonia shots? Half of clients have not had colon cancer screening. Half are past due for dental cleaning. Half haven't had a hearing screen in the last 5 years. Nearly 50% of eligible women haven't had a pap smear. 2/3 of people with developmental disabilities don't get regular exercise. And only 19% of clients rate their own health as excellent. There are, however, very high rates of use of psychoactive medications. About a quarter of clients are on more than 2 medications for behavior or for psychiatric illness, and more than a third are on at least one. So how could we have statistics like this with a population that is largely insured? And I think a popular answer is, it's because doctors don't care, and or because of biases. And I have definitely experienced and worked very hard on physician and clinician bias, and that can definitely reduce access to care. But there's a lot of systemic issues and policy issues that are driving this as well, and I want to talk about that a little bit. In an institution, a primary care doctor has about 100 patients. And in the community, a primary care doctor has usually about 2,000, in a place where there's fewer doctors, 3,500 patients. So it's an order of magnitude different in terms of the number of people that you're taking care of. And so if you have more than a handful of patients who need that intensity of care, then it's really hard to absorb the workload, frankly. And yet, if you only limit your practice, not that that's feasible or possible, but if you only limited your practice to a handful of people with complex disabilities, then you're not going to have enough experience to have any expertise. So that's a catch-22 for doctors. How do you get the experience, stay in practice, and have a manageable workload? Training is another issue. As one of my esteemed colleagues put it, she consulted me and she said, I recently saw for the first time an 18-year-old woman who has severe developmental issues. I'm happy to see her, but I have no training in any of the problems she has, and none of the problems which I am trained, she doesn't have any of those problems. I'm worried she would not get the best care from me, and none of my colleagues have any more expertise than I do, which is a weakness in our clinical program. So this is a new population. Adults with developmental disabilities, relatively speaking, is a new population that, frankly, people living in the community with these complex disabilities just didn't exist 40 years ago, and the healthcare system hasn't caught up to that reality. So we have a whole infrastructure for kids. We have a whole field of developmental pediatrics. We have regional hospital systems and specialists. And the medical problems that kids have with developmental disabilities continue into adulthood, and they develop adult age-related healthcare problems as well, and healthcare problems that we're only discovering as people age, and we start to learn what happens to people who have different genetic conditions or other conditions as they age. And but there's no equivalent infrastructure system for adults. People with developmental disabilities also sometimes need support to communicate what's going on in their bodies, or may have sensory or other differences that make it hard for them to recognize what's going on with their bodies and to understand whether it's something that needs attention, medical attention, or not. And so people with developmental disabilities often have undertreated or underrecognized medical problems. And in countries that have primary care-based national healthcare systems like the UK and Australia and different parts of the world, the most commonly used system for identifying that is something called a health check, which is a comprehensive questionnaire, sometimes administered by a nurse, sometimes administered by supporters with the client. that goes through a very comprehensive set of questions that helps identify some of those problems. It's not a substitute for your appointment with your primary care doctor. It's a support to that primary care doctor to help them recognize things that they may not recognize, because most of our healthcare system is set up to be very reactive. If it ain't broke, don't fix. We don't tend to dig for problems, and in this population, we need to dig and ask questions and not just assume that people will bring it up if they have a problem that needs to be addressed. And no matter how good a doctor I am, I can't help my patients if they don't have services and supports in place. I may not be able to get a full history if somebody doesn't have support for their communication and someone to help collect information. I can prescribe a medicine, but if my patient can't get it or needs help to arrange the insurance or go to the pharmacy or remember to take it or to tell me about the side effects, then I'm still not going to be effective as a physician. Medical offices aren't physically accessible. Many don't even reach ADA compliance, but some of our folks need physical accessibility that goes beyond basic ADA compliance, or the accessibility issues have more to do with being overwhelmed by sensory issues or behavioral issues, but even just the very basics, like having a wheelchair scale. They did a survey, and in California, only 3% of primary care offices even have a way to weigh someone who uses a wheelchair, and only 10% have even a high-low table that you can get on. So people are going to the doctor, but the basic things that you would expect to happen to the doctor, like you get your vital signs, you get a weight, you get an exam, aren't happening because we're not set up to do that. Another issue is that data is the foundation of public health, and yet people with disabilities are often excluded from studies and lumped in with much larger groups. I hear a lot of complaints. My doctor doesn't know anything about my condition. My doctor doesn't, there's great ignorance out there, and there's nothing in the medical literature, and that's true. And part of that is that it can be very difficult and expensive to enroll people with disabilities in research studies if they can't provide consent. And also, a lot of the protections that we put in place were put in place because of abuses to the disability community in the past. And those protections are really important, but we also need to not just figure out how to protect people, but also how to include them in the research that we're doing. Like other minorities, people with disabilities can be suspicious or distrust research because of historical abuses in the past, and sometimes the research priorities don't match the priorities of people with disabilities, so we need more people with disabilities going to medical school, becoming researchers, and participating in community participatory research models. Inadequate informed consent, threats to study validity, dehumanizing or stigmatizing language used in research, or the use of research findings to advance agendas that oppose the community values. So let me see where I am. I got 2 minutes to tell you my wish list of what I think we could do about all of this. Here's my top 10. So DBS has a section in the Lanterman Act that directs it to assure an adequate number of qualified clinicians. The department may contract with public universities to develop training programs, and that section of the Lanterman Act has a may rather than a shall do, and it's never been funded. But as a lot of people who are in the field have developed their expertise by working in developmental centers, and we're closing them. So we need and some of the medicine, frankly, how things are delivered, and the philosophy of care is a little different, and so we need to develop training programs, and they need to be funded if they're going to be developed. We need to fix the funding problems so that people, especially in the fields of primary care, psychiatry, dentistry, and therapies, have adequate reimbursement, that they can have those smaller patient panels. And I see that the ARC is supporting some legislation around better reimbursement for dentistry. I think that's a great thing. We need training and supervision and help for families and service providers and direct support workers who are performing these very important healthcare services, and who are those frontline healthcare workers. Access to nursing for people who have skilled nursing needs in their homes and communities is absent. We need a system for that, for having nursing in homes, not just group homes that have that as part of the service plan, but for people who are living more self-directed lives, they still need access to nursing. And I think we can incorporate that nursing expertise into day programs, vocational programs, SLS agencies, behavioral agencies. We can integrate a lot more nursing consultation into the programs that we have to address some of that issue. Home care is a great way of delivering care to this population, and there are other ways, telemedicine as well, which we'll talk about later. And we need to really monitor and pay attention to the extent to which hospitals are being used as the crisis placement of last resort. I'm seeing this happen more, where people are going into the hospital, they lose their housing, and then they're not sick, but they're stuck in the hospital for months, and that is a horrible, horrible, horrible place for someone to be if they aren't sick. It's really frankly a dangerous place for people to be if they aren't sick. And we can also address some of the healthcare disparities and lack of expertise in some of our more rural areas or suburban areas by having regional resources like we do for kids, and also having mobile teams that can go out to some of these other communities and provide services in their own environments. So with that, I'm gonna pass it on to you, Matt.
Thanks, great talk. I guess there's a mic up there, yeah. First, I want to thank you all for having me here, and very impressive group and great talks thus far. A lot of what we heard about so far has been about access to care and disparity in different incarnations, and I think telemedicine has a certain particular irony to this concept of access, because it improves access for people, right? You can see a doctor from your home or whatever, but in some ways, people with disabilities have been excluded from this technology improvement. In fact, some states make it particularly difficult to provide telemedicine services to people with disabilities, which it makes no sense, right? These are people that may be particularly beneficial. It may be particularly beneficial to have the access to a doctor. It might be harder to get to a doctor. It might be more traumatic physically, emotionally, multiple ways. I'll talk a little about that. But that really rings true in so many ways. I think telemedicine is just an example. And the technology part of telemedicine is really, it's sort of interesting, but what's really interesting to us as a group and what the work that we're doing, Dr. Mansour Khan is in the audience, he's one of my partners in this work. The work that we're doing is really, it's not about the technology, it's just about improving access to care. So let me just move on here. So we're ER docs, so we've learned over the course of our career what happens when someone shows up in the ER and what's going on. And one of the things that we've seen
certainly there are many people with disabilities that end up in the ER for reasons that may not be, appropriate for the ER. And there's a lot of reasons for that I'll talk about. But certainly we see that there's more utilization of the ER for people with disabilities, and particularly with IDD, than other groups in the population. These are some studies I'm not going to go through. And the other thing that we worry about on the ER, as an ER doctor, is who's going to get admitted. And we see consistently that people with IDD and other disabilities get admitted at much higher rates than other people in the population. Once they get into the hospital, what happens then? Well, as a hospital administrator for a bunch of years, I can tell you complications in the hospital are a big concern. And guess what? This group has more complications once they get into the hospital. Once that ball starts rolling towards the hospital, towards the ER, a lot of bad things can happen. And as Dr. Kripke alluded to, the hospital is not a good place to be if you don't need to be there. In fact, it can be a very dangerous place. And that danger can actually start just in the ambulance ride there. So avoiding it is a very valuable thing. So I'll take it the next step. Those people, after they've been hospitalized, they get discharged. Guess who gets readmitted at higher rates? People with disabilities. So there have been, and this is not an unrecognized phenomenon, this is something, there's been a couple of different efforts by CMS and other scenarios to reduce this phenomenon. There's something called patient-centered medical homes, which has had a roughly 25 to 33% reduction in ER use. It's been pretty effective, pretty impressive. Now these are sort of not ubiquitous, not every community has it. Telemedicine now, of course I'm biased, telemedicine, I mean, when Dr. Khan and I started this group and started these efforts, we did not anticipate the kind of impact we were going to have, but we've seen a pretty consistent reduction in ER utilization in this population of about 85%. Now, this is a policy conference. I want to mention telemedicine policy in California right now, and in fact, California is pretty evolved when it comes to policy. There's something called parity laws, which they exist in California, which says that private insurers are required to pay the same rate for telemedicine visit versus other types of visits. Medi-Cal covers this. There's no restriction on location. So in the old days, there used to be the doctor had to be in one place and the patient had to be in another place, and it made no sense because you're going to restrict the location. The whole point of telemedicine is to be able to see the doctor wherever you are. But it was different, so that's evolved, fortunately, particularly in California. Not every state has that. Unfortunately, there's no cross-state licensing, so a doctor has to be licensed in the state where the patient is, which is, we live with that, but I see patients from New York, I see patients who are in Ohio, for example, and I get to know them. So why are people ending up in the ER? People with IDD ending up in the ER? Why does it happen so much? There's a few issues that I think are probably obvious when we say them. One is they're high risk. There's a lot of comorbidities in some cases with people with IDD. There's defensive medicine. Doctors are worried about. You call a doctor up, say, hey, there's some concern. The doc's reflex over the phone is to send to the ER. Let's make sure that there's not some serious problem. And that's the easiest thing for that doctor to do. There's regulatory requirements. Some states actually have mandates that if there's a certain concern, the step that you must take is to call 911. And there are different versions of that, state to state. So, particularly I would say the traditional on-call physician is particularly inadequate for this population. There's no visualization. So you're on the phone and someone's telling you, Larry's not acting himself. What do you mean? I don't know, send to the ER. I mean, that's going to be what they do. That's what happens. There's no physical exam. If you're not able to examine someone, obviously you're having limited information. And then in most cases, there's no formal documentation. There's no closed loop encounter. If someone is evaluating someone, how is a doctor going to document that in a formal way so that other caregivers see what's happened? And typically the on-call physician is not doing that in the sort of standard model. And I'm going to give you a common example. It says common example. This is a real example. I saw this in the ER where I was. A 24-year-old man with cerebral palsy comes in with worsening cough and fever from his residential facility. So residential staff is concerned. Transfer the patient to the person to the ER. The patient arrives at 5:15. When they see me, they're a patient, so forgive my syntax. They wait in the hallway in the ER until 8 p.m. before seeing a doctor. Busy night. Blood tests, X-rays ordered. The man's mother gets a call from the residential facility, meets her son there, sits in a chair, uncomfortable chair next to the bed. Now, what's going on with this person with IDD? Well, they've undergone trauma of transportation. They're sitting there through the loud, disruptive environment. I don't know what your experiences are in the ER. California is a much more evolved place probably than New Jersey, but I will tell you, my ER is very, very scary for anyone. It's loud, it's nuts. And that person is exposed to infections. And then they're disrupting their whole sort of routine of life. Meals, sleeping, medications. So the mother there said, "Doc, my son is due for his seizure medication. Can you please give him a dose of this? He gets it at every day at X o'clock." Well, sure, of course I'll give you seizure medication. Problem is the pharmacy, we don't have it in the ER. We have to order it from the pharmacy downstairs. Please. So a couple hours later, it's going to show up. Well, guess what? The person has a seizure. Now you have a couple of problems. You've invented a new problem. They're there for something else. Now you have a new problem. Well, meanwhile, there's a giant book that's handed to the doctor, and he says, "Oh my God, I don't know what's in this book," and he puts it down. I'm just going to order everything. So there's all kinds of problems once that ball gets rolling down towards the ER. So the outcome is the patient stays there. It gets admitted, stays there, gets discharged 4 days later. So what's happening in the residential facility? Well, there's disrupted staffing schedule. Now they have to find someone, staff come in. There's a staff that's sitting there in the ER. They have to pay someone time and a half and lose their bed and all kinds of issues. Sometimes, depending on the state, they have to pay for the transportation, and they actually lose the bed itself. So telemedicine can come into it. I'm going to give you an example of what kind of work we can do. I will say this, you need docs that know how to do this. Telemedicine is not, like I said, some exotic thing. But you do need doctors who are trained to do this. And our numbers, I think, reflect the fact that we've taken the time to become trained in treating people with IDD. You're not going to have, a Dr. Kripke is a rare find. You are not going to find someone like her in every community. And likewise, you're not going to find a group of telemedicine docs who kind of know how to engage people with IDD, who are going to recognize that a behavioral issue could be because someone's got a urinary tract infection or has got constipation. I mean, these are issues that are not trained in medical school. This is a real lacking in medical school training. So our process, look, this is not exotic stuff. The way that we do it is the nurse or caregiver or staff member or loved one notices some change, a fever, a cough, whatever it is, gives the doc a call. We're able to evaluate the patient. Now it's a patient. The person is a patient. And by telemedicine with video conferencing, we have a stethoscope, and so forth, we're able to initiate a treatment plan and document. So a very similar case. Patient with asthma, restrictive lung disease, develops a cough and fever. Oxygen saturation drops to 90%. That's concern. In our very simple technology, we look at the medical records. Again, part of our model, and I think this only works if you do it in a sort of in-depth way, because again, we're talking about complex medical issues. As Dr. Kripke said, these are, you're not talking about a sore throat in anyone. You're talking about occasionally complex medical conditions. So we need to review the medical records. It's very simple. On the other end, it has to be simple. People have to be willing to do it. Let's see my time here. So we're able to perform an exam. Very simple. Again, the key is the person on the other end just has to be able to follow directions from us and engage with us. We have a stethoscope. We can listen to heart and lung sounds. This is standard stuff. Anybody can get this. This is not, I'm not out here saying how great stethoscopes over computers are, but it allows improved access to care. That's what I like about it. So a family member can be linked in this case. We can, if there's a lot of times a family member or someone off-site is concerned about something, so we can, in this case, bring in a family member to take a look at something. In this case, the physician assesses the patient. We order medications. In this case, it was nebulizer treatments, albuterol, steroids, and antibiotics. And in our model, again, it can't just be a transient model where someone flies in and out and that's all they do. You have to reassess the patient. You have to make sure they're doing okay. In this case, the patient's oxygen saturation was doing better. They were breathing more easily. And we were able to avoid a hospitalization, probably. So our outcomes have reduced by between 85 and 89%. I'm going to skip through this stuff. I'll just mention some of these just show the kinds of calls that we're able to handle. A lot of infections, URIs and pneumonias, cellulitis, and so forth. So lots of variations in calls that we're able to handle. Falls. I mentioned this already. Again, you really need, one of the keys to this is a committed partner, and that means a committed staff member, family member, and without that, it doesn't work. I will tell you that right now. We've had experiences where people don't buy it, and guess what? It doesn't work. It's not going to work unless you have a champion on the ground there on the front lines. So again, we have standards of care that we focus toward this population with experts like Dr. Kripke helping develop. And if you go in the community, you're just not going to find experts like her everywhere. So we run it like an ER. I'm used to running an ER, and Dr. Khan's used to running an ER. That's how we do it. We do quality control, chart reviews, and so forth. And I think that's important to treat this as its own entity. It's not a side sort of thing from a department. It's its own department that requires its own quality metrics and so forth. So I'll just mention very quickly, this is my last slide, but I just want to mention a couple of things. So none of this works. So we are very committed to the medical side of this. We are very committed to improving access for this population. This is really some of the most exciting work we've ever done. In my case, it is the most exciting work that I've done as a doctor. It doesn't work without policy. It doesn't work without economics behind it. Now, amazingly, that is one of the rare things in life where you're doing something right and it actually works economically as well, which is rare in healthcare. But here, this is just a quick example. If we cover 1,000 lives based on our reduction in ER utilization from the ER visit, we're going to save about $2 million to the payer. If we cover 1,000, just in ER visits, assuming that, and I can go over these numbers, we have a calculator that kind of assesses how much money can be saved, but avoiding hospitalizations is another, $9 million. So the payer is going to save around I misread the first number, it's 1.8, or 2 million. So the payer is going to end up saving about $13 million on covering 1,000 lives in this system. So economically, it's feasible. Of course, the challenge is to align the payers and the stakeholders so that they're willing to implement this system. But we're very, very excited about it. And again, thank you very much for having me here. That's my last slide. Thank you.
Hi. So I'm going to tell you a little bit about the ARC San Francisco's Health Advocacy Program, and then Gladys and I are going to speak about her experience as a user of our service. So I want to start out by giving you a little bit of history of where this program came from. And the genesis really goes back to 2003 when the ARC Senior Services Program, and that was serving individuals aged 45 and above, came to realize that their participants were having difficulty aging in place. They were experiencing falls, there was declining health, which was forcing them to need a higher level of care. Unfortunately, the higher level of care often was outside of the catchment area of the ARC San Francisco. So you had individuals who had been ARC participants for years and years and years. They had friends there, they known staff for a long time, they worked in the community. They had to move away, so all their connections disappeared. So the ARC really wanted to find a way to help people be able to age in place so they could keep these important connections. So they approached the California Endowment and received funding for a 3-year project called the Optimal Wellness Program. And that program tried to tackle aging in place from a few different perspectives. First was health advocacy and education. So they really focused on making sure individuals were getting age-appropriate health screens, seeing their doctors. Any outcomes from those screens, any treatment plans that resulted, they were there to support both the participant and the caregivers, whether they be natural or paid caregivers, to carry out those, to make sure that the person was following doctor's orders, taking their medicine. And they also did some health education, giving some ideas on how people could be supported to age in a healthy manner, you know, how to fix up your house so that you're less likely to have a fall in the house. There was a fitness component, so people, the seniors were able to increase strength and flexibility. There was a nutrition component that was mainly targeted towards board and care homes, but also to participants and their caregivers. And that was so that they could nutritionally support people who had chronic illnesses, a better understanding of what a diabetic diet was, what a low-salt diet was. And finally, a life transition component, because many of these aging individuals were experiencing other life transitions. They were maybe living with an aging parent who could no longer care for them and being forced into a new living situation. You know, maybe a parent died, or maybe they were just retiring and transitioning to a new phase of life, and wanted to make sure that there were no gaps in the healthcare during those transitions. Well, after 2 years, which was 2005, we saw a lot of successes. A lot of people were getting the age-appropriate screens. There was more compliance with treatment plans. There were fewer falls. And because it was so successful, in 2005, the Golden Gate Regional Center opted to vendorize the program, so it became available to more individuals. So fast forward to today. We still exist as a program, though we have evolved and grown. I came to the program in 2006, and I've actually worked there for 12 years, for those of you doing the math. But in 2006, there was a part-time director, service manager, and one health advocate. And between the three of us, we supported about 35 individuals. Today, besides myself overseeing the program, we have an associate director, we have a full-time manager, 11 health advocates who are supporting 130 individuals with a wait list of 40. So we're a service that's in demand, and I think there's several reasons for that, one of which I think we provide a great service. But also, part of our evolution has been who we serve. We've expanded our services to include those age 18 and above. So we're a lifelong service, adult lifelong service. And one of the reasons for that is because of the types of, the increasing complexity of issues that we've seen coming in. We have more people with mental health issues. We have more individuals that are struggling with addiction. We have folks who have behavior needs. And we're seeing more folks who we're supporting with potentially terminal illnesses. In addition, with that aging population, watch it back up. we're in San Francisco where housing is just a nightmare and that there is none. So we have individuals who are actually in boarding care homes. The boarding care homes are closing, but the ones that are open have aging providers. So even those providers who would normally be taking on the role of making sure people got to the doctor are aging out of that. So health advocates are brought in to support that. We also have more folks living at home, unable to live independently, so they're still either staying with their parents or maybe moving with a sibling. So there's just more need for that kind of support. So what is a health advocate? I define a health advocate, my health advocates, as people who partner with participants, providers, and their caregivers to promote positive health changes through support, access, advocacy, case management, service coordination, and communication. In a nutshell, I like to call what we do health case management. What we do is we try to use a strength-based approach where once someone goes through assessment, we really get familiar and identify their needs so that we can partner with them and empower individuals to participate in their own health as much as they are able to. And in that process, we wind up doing a lot of service coordination and advocacy. So on the most basic level, we provide access. A lot of folks come to us who haven't seen the dentist in a really long time, don't have a primary care physician, may need a podiatrist, and I think podiatry is an extremely important service that's needed for people with IBD. So first step is to make sure people actually have providers that they can see. Once we conquer that, it really becomes a lot about partnership and communication. We set up appointments for people. And then prior to the appointment, a health advocate will meet with the person they're working with and talk about what the appointment's about, providing that kind of support to take away the surprises. We're going to see your doctor because of ABC. What do you want to talk to the doctor about? Is there anything you're concerned about? We prep. We also speak to, of course, always with the permission of the participant, other people in their lives, so we can fill in any gaps. The health advocates don't see people on an individual or on a daily basis, but their job coaches do, their family members do, their ILS workers do. So we talk to those folks so we can get a more complete picture of what's going on. So when we walk into that doctor's office and we have our 15 minutes, we really can give a very accurate picture to the provider so that they can provide the appropriate health care. Once we get into that office, it's really about facilitating the communication. We are lucky enough to be in San Francisco with UCSF, and we've kind of inundated them with health advocates and the people we support, but many doctors haven't really worked with people, adults with IBD, and they really don't always know what to do, what to say, or even that they actually can ask the person about their health. And so we might walk in and have the doctor ask the health advocate, so how's Gladys doing? And the health advocate will model and gently redirect the doctor and say, Gladys, can you tell Dr. Kripke why we're here today? Though Dr. Kripke would never do that. So we really try to facilitate that communication. So, and again, the health advocate is there to fill in the gaps in case the person, is not a great historian, isn't a good self-reporter. We can provide cues and fill in those gaps so the doctor has that picture. Once we're through the appointment, we'll walk out with a treatment plan and medical directives. Often that falls on the health advocate, at least parts of it, to make sure that gets followed through on. So we might be setting up more tests. We might be setting up appointments with specialists. We might be communicating with the pharmacy if a medication problem has been discovered. We might be calling a durable medical equipment company to figure out what's up with the CPAP, things like that. But it also means communicating with the actual people who are supporting the individual on a day-to-day basis. So that could be a paid caregiver, a natural support, so we're sure that they understand what kind of support the individual needs to be successful. It could be a dietary change that's needed at home. It could be, more exercise. Anything like that. It could be we might need to help the caregiver set up a more manageable medication system. The health advocates don't manage medication themselves, but we can help people set up systems that work for them, because medication can be very confusing when you have a lot of medications and frequent changes. We also advocate for better communication amongst providers and team members. So when you have an individual who has a lot of complex issues, they often have big teams. You might have, you've got the primary healthcare system here, but that person might have a psychiatrist that's completely outside of that system, and a behavior consultant who's outside of any system. They have the people in their lives who are providing the support. They've got a Golden Gate Regional Center case manager who doesn't have the ability to have the knowledge of the day-to-day needs. So ideally, everybody would know the same information, so it could be a cohesive unit supporting the individual and everybody kind of coming from the same perspective. That doesn't necessarily happen organically, and the health advocate ends up being kind of the connective tissue that really ensures that everybody has the information they need and connects should they need to. If the psychiatrist needs to talk to the primary care, we'll make that happen, so that really the person can get the quality of health care that they need. We also are there, we advocate for additional supports. Like I said, Golden Gate Regional Center case managers don't necessarily have the ability to know what's going on in their participants' lives. They have huge caseloads. We have a little bit more of an inside perspective, so we can advocate for somebody needing maybe more ILS services or referral to, for new housing because the situation they're in isn't really working for them and affecting their health. We can, we're there for in crises. We have people who have health crises, sometimes not directly related to health, but people who are in housing crises, but we know if you don't have housing, your health is going to be directly affected by that. So we try to step in and be part of that team that addresses crises. Often those are emergency room visits, which may lead to hospitalizations. We advocate strongly in the hospitals because, again, the hospital doctors don't necessarily know the individuals who they're working with. We've got a really good foundation of information. And I think a key role we play is when folks are being ready to be discharged. There has been, I found, an assumption that many individuals in hospitals make that if someone has an IDD, they are going to walk out with 24-hour support 7 days a week. And of course, that's not the reality, nor should it be the reality. But you really have to advocate with the hospital sometimes to ensure that somebody walks out there with appropriate support so they will actually not get worse by going home. And in some cases, the answer actually is a skilled nursing facility because that's really the level of the support they need, even though they don't need to be in the hospital. And again, we work with the skilled nursing facilities as well. In a nutshell, that's what a health advocate does. And just to give you just a really quick idea before Gladys and I have our chat of just kind of the range of complexity that we work with. So we have one woman recently we worked with who's about 30 years old. She had a mental health diagnosis for which she was not taking her medication. She also had some pretty serious addiction issues, a history of trauma, very unstable housing, and she was pregnant. So health advocacy was brought in to ensure that she was getting the support she needed, so making sure that this woman got to her doctor's appointments, was getting the psychiatric services that she needed, which she would directly show up in the ER, and the health advocate would be there to work with the team to ensure that they understood what was going on. I'm happy to say that she was able to deliver a healthy baby. We're still working with her. She still has a lot of mental health issues that need to be treated and addiction, but we're right there with her and really working toward getting her to a better place. And then we have another woman who we have supported her through an initial cancer diagnosis, and she's an individual, and I think this is always really critical, who presents as very capable. She'll walk into a doctor's office, and she did for years, saying, yes, I'll do this, yes, 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 and she really wasn't understanding what she needed to do. She wound up with a cancer diagnosis. We helped her understand what her options were. She opted for treatment. Thankfully, she went into remission. However, it came back, and now we're helping her be able to make the choices she wants to be able to die well, and that is to be able to die at home, and the health advocate has been right in there supporting that decision. So it's kind of the extreme ends of what we maybe do. But Gladys here is also uses our services, so we're going to talk about that, and I'm going to kind of interview her here. It might be easier if I do this. Okay. So, Gladys, you have been with the ARC Health and Wellness Service since about 2011. So, can you tell me why did you want a health advocate?
To go on appointments by myself, but also have the support.
And who was taking you to the doctor before you had a health advocate?
My mom, my family, and I had good doctors.
I'm happy to hear that. Was it helpful as an adult to be able to go to the doctor without your mom?
Yes.
Okay. And what does your health advocate do for you?
She tries to remind me if I have to ask, if I forget a question, I ask her to the doctor. She writes it down, makes notes, and then if the doctor gives me a new prescription or new medication that I don't know what it's called or what it's about, she breaks it down to me in plain English.
That's great. So that sounds like it's probably helpful.
Yes.
Okay, so we had talked earlier, and you had a bit of a health crisis last year that your health advocate helped you with that. We were going to talk about that a little. Are you still okay with that?
So.
We are not revealing any details here, major details. So stop me if you want to, but you had an infection last year, is that correct?
Yes.
And how did the doctor want to treat that infection?
Surgery, major surgery.
Would that surgery have affected your life?
Yes.
Yeah. In a pretty big way?
Yes.
Okay. And how did your health advocate, how did you feel about that?
I didn't like it.
Yeah.
It scared me. Made me upset.
Yeah. And how did your health advocate help you in that moment?
She jumped in and she asked the doctor to think of other options.
Mm-hmm. Did you want the doctor to think of other options?
Yes.
And did the doctor think of other options?
Yes.
That's fantastic. So what was the other option?
Just go in and remove
The problem?
the infection.
Mm-hmm.
And now I'm doing much better.
And you only had to stay, it was pretty quick surgery, wasn't it?
Yeah, it was an in and out kind of thing.
And has your life been affected in any big way because of that surgery?
No.
And how do you think things would have turned out if you didn't have a health advocate?
Not so good.
And would you recommend a health advocate for another person?
Yes.
I'm glad to hear that. And anything else you want to add?
No.
Okay, thank you.
Thanks. So now we have some time to have a discussion. So I just want to, after having heard that, ask you, Matt, what are some of the barriers to implementing telemedicine?
Great question. First of all, Jennifer, I want to say, and Gladys, what great work you're all doing. I wish that this was a ubiquitous, health advocacy was a ubiquitous phenomenon. I can tell you that this would impact care dramatically in the emergency department, for one thing. So congratulations on that. Regarding barriers to telemedicine, that's a issue that we hear about a lot, and I would say really it falls into two categories: regulatory and financial. So as I mentioned before, there are certain states that have certain sort of barriers that make it difficult to implement, and it really, the way that I see it is that it functions as sort of depriving a group of a service that a lot of people are enjoying. I don't know how many insurance plans are pushing telemedicine on people to use for their sore throats and so forth. To me, it seems like some regulations end up making it more difficult for people with IDD and other disabilities to use it. And I'm sure that's not the intention of these regulations, of course, but it's the effect sometimes. So that's one. California, I'm learning about. So I'm certainly, new to, or in the process of learning about the policies and the regulatory issues, but I don't know of anything specific that stands in the way. Reimbursement, it's a challenge to find, to create the incentive enough so that the stakeholders that are actually paying for emergency room visits and hospitalizations sort of are willing to say, oh, I'm going to create a new way to do something, create a new bucket for my budget to take from to pay for telemedicine services. Now, even if they're going to save a ton of money, it's still a challenge to get them to spend that $1 to save 50, believe it or not. So getting those stakeholders involved and committed is the big challenge.
So you're using a model that I think one theme I heard from everybody was that it's a partnership, that you need somebody on the other end who's helping you, and I use a lot of distant telemedicine just with a simple device, my cell phone, not anything fancy, but I have a nurse on the other end who's the support, and you certainly have a lot of experience with the health advocates who are just fantastic and really who enable us to provide good care. So we're grateful for that, and I want to ask you, Jennifer and Gladys, what do you think would help? What do you think on a policy level would help, or what do you think would help move us forward to get better care, since you're on the front lines?
I would love to see health advocacy scaled throughout the state of California. As far as I know, we're the only organization doing that kind of work in California. And from the beginning, we really, I believe, have been informally practicing supportive decision making. It's the health advocate's role to ensure that the individuals we work with have information about their own health that's accessible to them in a manner that they can understand, and the support they need to be able to make their own decisions about their health, whether it be, am I going to get a flu shot, to should I have surgery A or surgery B? And I know if we could be part, because we're available to more people, of a supported decision-making model, I think people would feel more comfortable not moving towards medical guardianship, which I think happens in a lot of situations because people are afraid, and understandably so. Your health is your life, and people don't want individuals to make wrong decisions or not have the information they need. And I really believe with more health advocates out there, we could have people who are able to support individuals to make decisions that are really the best for themselves. Gladys?
Have the doctors talk to the patients instead of the health advocate.
I see there's some people who want to get in on this conversation. Go ahead.
It seems to me that medicine might want to consider making a new specialty, that a developmental disability. It seems to me that medicine might want to consider making a new specialty, developmental disability medicine, like we have specialty in heart, with neurological specialty, brain surgery specialty. People are specialists in many different fields, brain, heart, psychiatry. Perhaps we should consider making a new specialty, that of developmental disability medicine, and develop a whole group of doctors dedicated only to dealing with the problems that developmental disabled people might face in the medical field.
That's an interesting idea, and there is one country, the Netherlands, that has such a specialty. I think in this country that idea has met a lot of resistance. A lot of people don't want to do that because they worry about fragmenting care by splitting people up too much so that people don't have the broad perspective, because disabilities just run the full range. But I do think that we should be paying for some regional resources and for some doctors who really make this their focus, and I think we can do that without a new specialty. Yeah.
Yes, Stephen Davis. So in special education, it's like 1 in 10 kids have a disability. In adults in the population overall, it's bigger than that. Why don't we simply make, for teachers and for doctors and for other professionals, it'd be a licensing requirement for all of them to be able to adequately support people with disabilities?
Do you mean to provide any type of service to them? You know, like, are you talking about like in-home caregivers as well, or just the doctors and the?
If you're in the field, you should be able to support 20% of the population, right?
So I usually think about this issue. You have a good point that disabilities are common. Why are we doing such a lousy job? There are some things that are just plain inexcusable, like there's no excuse for not having a wheelchair scale or a high-low table, because you're right, 20% of the people and probably a higher percentage of the people coming to your medical office need that basic accessibility equipment, and all doctors should have some information on communicating with people with disabilities and on disability etiquette and on many of the issues that come up for people with disabilities in terms of healthcare. So I think that is a good idea. But when we have other populations like adolescent health or geriatrics, or we have other migrant health, we create a few specialists. It's not that everybody who is older has a geriatrician for their primary care doctor, but we create a few people who have a little more expertise, who can do that research, who can do that training, who can have a teaching clinic where people can get some experience. And I think about this in terms of training for doctors, in terms of exposure versus experience. So exposing people to people with disabilities is something that's feasible to do for all doctors and all healthcare professionals. Having real experience to be able to take a really complex situation and break it down is going to take years of a more detailed training, and we can't do that for everybody equally.
I will tell you, I agree that there's certainly missing pieces of medical education and services. I couldn't agree more. The experience in the ER, of course, is we see all comers, but that doesn't mean we see all comers in the right way, and we certainly could use a lot of that philosophy, particularly in the emergency department.
Okay, I think my question is more for Jennifer. As a parent of a disabled adult, going to the doctor and communicating with the doctor, even knowing my son very well, can be very difficult. So when you have a health advocate, do you do training of them in interacting with the doctor? Also, of course, in interacting with the individual who's going to the doctor, but what kind of training, is that something that you'd be willing to share?
Sure, we're always trying to update our training process, but really, I think one of the major things we look for in a new health advocate is the ability to communicate well. Ideally, having worked with this population before, so there's some familiarity. But we do some basic chronic illness training. A lot of what we see, a lot of the diabetes, the high blood pressure. Making sure that the health advocates shadowing other health advocates who are really experienced really helps. But we really do rely on family members to provide the history and help us work better with individuals when the family members are involved. Many times what happens is a parent who has been supporting their adult child for many years is hesitant to maybe have a health advocate come in, which is perfectly understandable. So we'll work together. We'll attend appointments with the parent and the individual so that the comfort level develops, the providers get to know everybody, and there's trust there. And I think what we see that many parents feel pretty comfortable pretty quickly because of the level of support and information that we provide.
Gladys, I'm wondering if you could also address this. Do you think that self-advocates also need training about their own health conditions, and when do you think people should start learning about their own health conditions?
Yes. And as soon as they start to walk and talk.
One more question.
This is for Dr. Kaufman. In your experience with your telemedicine situation, have you spotted any cases of abuse and neglect? And or do you have a specialized training? Because I realize this is not maybe difficult when you're relying on the caregiver or the provider to give you some information.
It's sort of standard as emergency physicians that when we encounter sort of suspicious constellations of findings that we do at least consider that. Our partners in this, my short answer is no. Our partners in this have been, my perception has been they're very dedicated. This, again, as I sort of mentioned, this doesn't really work. A program like this doesn't work unless you have partners on the other end that are very committed to making it work. But it's something that we need to consider when there's an injury or when there's just signs of someone being neglected. In the ER, I'm very sensitized to this, but we have not seen it in this context.
Can we give a big hand to our health panel? Thank you guys so much. That was really